or when they're sick and their insurance has got such a threshold that it doesn't cover any or much of the cost of their care, because we already are doing that way too much. So I don't necessarily think that it has to be decoupled. I think we could, if we agreed on a level playing field and what it would be reasonable to expect of employers, and that wouldn't mean that as an incentive you couldn't offer more, but it would mean that at least everybody had to do the basics, and they could either do the basics as part of a direct purchase, or they could do the basics as part of a government pool. That doesn't matter. I'm really open to any of those as long as we level the playing field. When it comes to a single payer, I know there are a number of groups that are out there saying, you know, we're never going to drive our administrative costs down until we get a single payer. I think we could drive our administrative costs down significantly without getting to a single payer. But, you know, if it was the will of the people of this country to go to a single payer, I wouldn't be one of the people up there saying that'll never work. So I'm not driving to a single payer, but I'm not afraid of that concept either. I'm willing to talk about it.
Sister, welcome to Cleveland.
Thank you.
You've offered some very powerful economic data in support of the argument that we need to do something about this, and I think many of us have used similar data to try to convince business leaders that it's in their informed best interest to do something about this. My question is, must we concede this argument to economics, particularly in the faith community, as opposed to also balancing the economic argument with the fact that it's arguably unethical, perhaps immoral, to allow large segments of the community to not have access to health care? I think back to the civil rights movement, and in that area, the faith community was very helpful, and they used arguments of morality. Mm-hmm. And in one sense, I kind of hate to see the faith community conceding that argument and using the arguments of the marketplace to make this case. There are others who can make that, and I hate to not have the balance of the argument of ethics and morality about how we treat people in this country.
I think that's a very, very important thing to say, and quite frankly, one of the reasons I talked about the misery that people face and the struggles that they go through, and how difficult it is even for some of our insured people to do this. I absolutely believe you're right. And I believe you're right sort of in the same way that instead of getting another degree in either advanced nursing or in theology, I got a degree in finance, because sometimes you have to fight the issue on where it is. But never, never should you be there fighting that issue unless you're there for the moral and ethical reason. And so I remember one time a nurse said to me, that she said, I came to Providence for the money, and I stayed at Providence for the mission. And if I can get people to the table for the money, I believe America is so compassionate that when they start to really meet the people that are hurting, you just look at how our hearts have gone out to the people of Myanmar, to China, to the people in the southern part of our country. We are a compassionate nation. You put up a child who needs a heart transplant or has a very disfiguring condition. People in this country want to do whatever it is they can to help. Sometimes to get people in the door to meet folks, I have to use economic arguments, but I would always say you are absolutely right. The most important argument and the reason we should stay at this, the reason CHA should be at this, is always the ethical issue. This is no way to treat anyone. It's no way to treat someone we believe is made in the image and likeness of God. It's no way to treat a person in our country we say that the right to life, liberty, and the pursuit of happiness, and our Constitution guarantees you the right to bear arms, but not the right to have health care.
I appreciate your principles that I think are well laid out here, and I'm trying to translate them into actual actions. The first one, I think, as I interpret what you said, says mandatory coverage of certain conditions for all health care plans, particularly preventive care. I think you've made that pretty clear. The fourth one talks about cost effectiveness, and the sixth one talks about quality. And I'm a little more confused about how you translate those into actual action, particularly given the wild variations that we know exist from the work of John Wenberg at Dartmouth and others about how wild our system is. How would you translate these two principles into practical action to actually narrow that gap?
Well, that's a very good question. And some of it goes back to what I was talking about earlier when I talked about the many people who feel we have a need for an independent center to evaluate new methodologies, new equipment. Because we want to spend the money we need to spend to help people live well, get better, be prevented from sequelae of their disease. But as any clinician will tell you, the best care is the least expensive care. Doing it right the first time, preventing problems, and incentivizing people to prevent problems in our healthcare system will do that. You'd have to sit down and quantify each one of them. We believe that it is much more cost effective to really evaluate, as I use the example of a back pain. At what point do we need to put you into an MRI machine? Or at what point do we need to use hot packs, physical examination, physical therapy, walking, and some exercise programs? At what point do we need to put a surcharge on you if you're 250% of your reasonable weight, or you're smoking, or you won't use seatbelts? So there are a myriad of things that go into that. The most important that I believe is the quality of the health care that you receive. And also not to have what I call perverse incentives to people to add treatment upon treatment, methodology upon methodology, a new drug that just came out just because it's a new drug, not because you've been having any trouble with the other drug, or because the spin on television says that if you've got cholesterol, this is the be-all and end-all. You don't want to be taking last generation's drugs. So I think that there will be a whole host of things that we'll bring together, and using our National Institute of Health, using another independent group, and some of the things people are doing to, some of the researchers we're hearing now who are saying, I will simply not be an advisor to that drug company. I will simply not do this because what it's doing is creating a conflict of interest. So dealing with all of those things, I think will help us. Preventing an infection in the intensive care unit, preventing a post-op infection, so many of those things are so cost effective and are cheap. Very, very, very much less expensive than treating them. So we could go through a million different conditions, but that's sort of where we're coming from.
Thank you. Today at the City Club of Cleveland, we've been listening to Sister Carol Keehan, President and CEO of the Catholic Health Association of the United States. Thank you, Sister. Thank you, ladies and gentlemen. We are now adjourned.